So shall we have 15 minutes for discussion? Any questions anyone would like to ask? And then I will wrap it up for 5 minutes and then we can go for lunch.
Just get some hungry voices.
Hungry voices. Yeah, please, madam. Please introduce yourself and ask who you would like to ask a question from.
Good afternoon. I'm Dr. Maya Mascarenas. I work with an organization called MyRada, and we work a lot in primary healthcare. I have a question that cuts across 2-3 speakers. It starts with Amit's last statement. Are we really talking about health coverage or health care? Because the former really talks about numbers and it's very, very quantitative, whereas health care then brings in the whole quality issue. And we talked about the regulation, and we seem to limit regulation to only the private sector. What about regulatory mechanisms for the public health sector? Geeta did bring up the issue that the group discussed it. And what is the role of the community in this whole process of universal health coverage? It seems very top-down, very provider-oriented, and finally, if the community is a beneficiary, how do they have a voice in making sure it's equitable and participative?
Okay, I will request the panelists to make a note of these. We'll take about 4 or 5 questions, and then if they're not directed specifically to a panelist, I'll request the panelists to answer whatever they would like to. But I also request you all to please limit to 1 question. Let's have some rationing. Yes, sir, at the back.
I am Indran. I have one small question.
Could you introduce yourself?
I work with Public Health Foundation of India. Okay. As a public health practitioner, I have trying to understand how the concept of packaging public health can be done. Because we have been taught that it's about comprehensiveness, it's about universality, it's about equity and all. How in this model a concept of packaging can be fit into, if somebody would care to explain me? Thank you.
Okay. Any other? Yes, sir. Yeah.
I'm Shankar Preja. I work as an assistant professor of health economics at School of Public Health in PGI Chandigarh. Although we might differ ideologically on whether it should be publicly provided or private providers should have a role to play, but considering that we have the current scenario of health financing, where we have so many insurance models which are being rolled out in different states, and we have created a situation where public sector is supposed to compete in some way or the other, why do we not talk about some sort of payment mechanisms, which Dr. Professor Anvils tried to touch upon, but trying to create certain incentives for the public sector to compete and to build in those provider mechanisms.
Okay. There was some, yeah. Please.
My name is Shantvi Patil. I work for RSBY Bangalore, Karnataka. I have a question for Mrs. Geeta Singh. So it was a very wonderful presentation of her presenting a lot of insights on implementation processes in RSBY. So in the background of, in the context of the 2 critics she made and one unviability point. So this is where my question is coming from. Whether that was meant for on a specific state, that unviability picture, because once the beneficiaries utilize the fullest maximum level, then the survival become difficult. So is it really a specific to a particular state or the generic to the whole country in the implementation process, because that will help us a lot. And then what could be the kind of recommendations on these lines? Thank you.
Okay, one more question and then we'll ask the panelists to. Any other? Okay.
Hello. My name is Dr. Siddharam. I'm a student of MPH first year from KLE. I need to ask, Girija ma'am has stated, defining role of Ayush and community health workers is a controversial statement still in the many states. I'm not getting, since many of years we are hearing this statement, but still we are not outcoming us. During my degree also, the same question was been asked, but still it is in the question only.
Okay. So, Girija, would you
Madam,
like to
with the Tamil Nadu experience, I am asking. Madam, I am from AP Civil Assistant Surgeon, now in the panel of the Deputy Civil Surgeon, Madam. Previously, I attended the PDC and completed the PGDPH, Madam. And most of the times, there are the explanations that we have to learn so many things from Tamil Nadu, Kerala and things. But is there any difference between the smaller size of the districts and the larger size of the districts, which is very, very important in AP? In AP, out of the 2/3 districts, that we 15 districts out of 23 are more than the 10,000 square kilometers. In Tamil Nadu, only except Dharmapuri, it is really nearby to the 10,000 square kilometers, but most are around 3,000 or 4,000 square kilometers.
So what's your question?
He's asking about the size of districts.
The size of the districts is playing a greater role, but do you accept it or it is a negligible role?
Okay, thank you. Professor Mills, would you like to respond to any? I mean, any of the panelists?
I'll be really brief and leave some questions to other. I think this issue of the role of the private sector is really tricky. I mean, my personal view is that the cat is out of the box, or whatever we put it, that it's better to incorporate it in the framework than to allow it to flourish outside the arrangements. And therefore, I think the key issues are, picking up a couple of the questions, what sort of payment mechanisms are appropriate that will indeed maintain the public sector while allowing the private sector to have some role, and indeed how do you strengthen the public sector in order to effectively compete. And I think we do have models across the world that demonstrate that it is possible to have both private and public participation. In Europe, people don't worry whether they're going to a privately owned or a publicly owned facility. They wouldn't probably know that. Our GPs in the UK are technically private, but we regard them as part of the NHS. So I think it's possible to incorporate private providers within a nationally public system, but I think it's key how you organise those arrangements, how you regulate and how you pay.
Thank you. Geeta? Do you have a mic?
Oh, sorry.
Yeah. Okay.
Okay, lots of questions, but I would just say on this public-private thing, we were pretty much going on the basis of that experience to say that the cat is out of the bag, and the private providers are there, and it's far worse to leave them outside the tent, completely distorting and skewing up the system as they have a tendency to do. Having said that, let me reiterate what I said about the importance of strengthening and supporting the public system so that it can then do its job in terms of bringing for itself and for the private sector. There was a question about the regulation of the public sector. I knew this would happen because of the time. Questions of community, I would recommend that people read the report because a lot of those things are spoken about, and definitely one of the things that the regulatory architecture is meant to do is in fact to ensure that the public services and facilities as much as the private ones, whoever is in the system, is regulated properly, and even the private providers who stay out of the system would still be regulated, would not be outside the regulatory framework, but definitely a recognition of the poor quality, bad functioning, and problems in the public system as well. Those need to be cleaned up. Incentivizing the public sector to compete, I think that is very tricky. And I think that one doesn't, I mean, the route that has gone in the experience of countries that have tried to combine public and private and throw them into the same swimming pool and say, okay, let's see who can swim best in this, has been disastrous by and large, unless one is able first to make sure that the public system is actually quite strong. Secondly, one can't throw them in to compete, just as one can't do it on a lot of other public services. If you want the services to be universal, to have reach and so on, they will be doing different things quite often, and the private providers won't come in to do a number of the things because it's not profitable enough for them. And you can't, turn them into, charity purveyor. So that distinction will be there. For a universal system, you cannot have the two competing. There is no level playing field in that sense between the two. And so one does things like South Africa. Packaging, everybody imagines that it means a World Bank given essential package, which is limited, which says you will get so much and nothing else. That's not the way in which it works. Ultimately, you have to decide for the money that you have in the system, what is it you're going to be able to provide? Whether you do it positively, whether you do it negatively, and Anne pointed out that the Thais, for instance, don't bother to specify a package. They simply say what it will not cover. The system will not cover
Plastic surgery.
Plastic surgery,
okay,
for example. But in the NHS doesn't cover eye and dental. So, you know, is it essential? Of course it's essential. But, you know, these are things that have to be worked out in the system, and so one shouldn't get into the thing of, oh, package means something narrow.
Girija?
I had two specific questions. One was regarding Ayush doctors. I put it there because you're right in saying that we have to find a way to integrate them, but I put it as these are the areas where we need to think it through carefully of integrating Indian systems, because the report makes a very strong recommendation that they would be used. Maybe read the report carefully. It does talk about using them for a lot of things. We have to sort out. The second question was on the size of the district and backwardness. Our own experience has been mixed. We split Perambalur district, which was one of our bigger districts, into two more districts. They still remain backward. Backwardness seems to be a combination of issues, one of which could be administrative ease. But Dharmapuri is a bigger backward district. I have Perambalur and Ariyallur, which are smaller backward districts. On the question which Geeta mentioned on funding, on incentivizing public facilities, actually they started preliminary work there in NRHM, though not, as she says, they cannot compete equally. But incentivizing them, at least you can look at little bits of push towards better performance, which will, it's a baby steps. We have to take those baby steps.
Amit, would you like to have any? Do you want to say anything?
Just a,
Sorry.
Yeah, no problem. Just a couple of points. One on the public-private competing debate.
Is your mic on? I don't think.
Debate. I think we need to overturn the discourse. It's not. I don't think the issue is one of the public sector being asked to compete with the private sector. It's the other way around. That you need a strengthened, expanded public sector with which the private sector is then forced to compete, because any regulation of the private sector will not work unless you have a strengthened and expanded public sector. So that's actually the real way in which you can regulate the private sector meaningfully. The question about how can packaging be done, I think Indranil, you got the question wrong. The packaging that is being done today is not about public health. The packaging that is done today is about medical care. And also it's not really about medical care, because I wouldn't use the care in this case, but medical services. So the first step is you have to take out medical care from public health, and that's the whole way in which packaging is done and needs to be done. So yes, packaging can be done if you take out medical care from public health, take out care from medical care, and just use it as a kind of providing services or facilities, like lawyers and chartered accountants provide services, and then you can of course package it, dice it, and sort of mix it up. And so I think that's really, and finally I would say that responding to the European experience, I don't think it's fair really to compare the private sector in Europe with post-colonial countries. If you really look at the private sector today in India, and I'm not talking about small practitioners who are unqualified, which is the bulk of private sector in the rural areas, but the organized private sector, which is really sought to be seen as the messiah which will provide healthcare in the country.
I will.
It is huge. It is integrated. It today integrates pharmaceutical corporations, insurance corporations, and corporate healthcare. So that is the private sector that we are talking about, very different from the general practitioners in the national health system. So I think that's the distinction that we need to understand.
Thank you, Amit. Deva?
Yeah.
This may, yes.
I think
It's working.
It is working.
Yeah.
I think most of the panelists have said, but most of the things. But I just wanted to say that we have to be a little careful when we talk of private sector. And I think what Amit was saying, it's not a homogeneous body. Huh? There are people. I mean, we have been working very closely with private practitioners here in Bangalore, and we find people who say, listen, I have to make a living. I have to charge a fees. But I also care for my patient, because if I don't care for that patient will not come back to me. So it is not fair to say that all private is bad and all public is good. There are shades of grey. There are private industries which are for profit and which will exist, but also there are private sector which is, I mean, out there to help and serve the people. So I think I would like to end on that note.
Okay. Thank you. Now I'd just like to summarize what we've been discussing for the last 1.5 hours. If you recall, Dr. Ann Mills had given us an excellent overview of what is really happening on the financing systems in other countries, which was, but ended with the message that really you can't transplant health systems from one country to another. It has to be a health system development, and universal health coverage in countries have to be context specific. They're very culture, political, administrative, institution specific, and probably not even within the country. Tamil Nadu cannot be replicated in Jharkhand and so on. So there is a huge amount of, the message there is that we in India cannot just simply take capitated form from Thailand, another system from UK, a managed care model from US, and cut and paste all those and say this is going to be our UHC model for India. So that's a big challenge on all of you researchers to really come down and look at evidence to see what kind of a UHC, what kind of a health system which is equitable, efficient, and affordable for us comes out of our own reality and our own experience. Geeta gave an overview of what the HLAG report had said. I think, as she rightly made a disclaimer, that she's not speaking for HLEG because she did not mention one of the red herrings on which Amit and all get very upset about, and so do many of us, and that's a recommendation 310, which really very clearly stated that call for integrated provisioning of integrated healthcare through tertiary, secondary, and primary integrated networks to be contracted by government. Now, the implication of that, and I'd like you to recommend you to read that, that is where the whole conflict between government and the HLEG report and the Planning Commission, which has adopted it, has come in, because this is a call for corporatization of the health sector. Who can really give you that integrated network? It is the Apollos, it is the Maxes, it is the Fortises, and this is where, once again, this is a challenge for us to study what is going on in the private sector. We really don't have much research on what is going on. How is the private sector aggressively getting into the market depths? How they're doing vertical consolidation, how they're doing horizontal consolidation, and how these networks are developing. And if we go into that kind of a thing, soon we'll have about 10 or 15 hospital chains providing the entire market healthcare for Indians. Is that possible? Now, this is a model that has been taken from US, and US itself is struggling with this model because it has failed to contain costs in the US, and it is considered to be a failed concept, both in terms of containing costs as well as in terms of driving down quality and several other implications. This is not a lecture on managed care, but this is again an issue thrown to you all to do much greater research and study on seeing what are the implications of such recommendations I can hear Geeta say, no, that is not mean. But the point is, we're reading the English as it has been said. And then when you read that and the implications of it as it's being rolled out, this is what it really comes to. And this is where I think we need to do much more research to understand how is our private sector moving, what is happening in the private sector, how are they pushing, there's some goods, there's some bads, and how do we minimize the distortions, if any, that they're creating in creating a more equitable health system. You know, a need for, Deva really brought down and flagged the need for greater evidence, a greater understanding of the data sets that we have, which I'd like to reflect in my concluding remarks. Girija gave her own experience as a health secretary in trying to operationalize some of the critical recommendations made in the HLEG. And this is coming from a state which HLEG itself lauded as one of the best performing states in the country. So if this is the condition of Tamil Nadu, then please think in terms of Jharkhand and UP and Bihar and Chhattisgarh, where there are hardly any provisioning of healthcare either by the public or private. My assessment as a former health secretary, I would say that at least 300 districts, 50% of our country doesn't have any credible provisioning of healthcare services, even for the minimal basic healthcare. TB, malaria, and so on and so forth. So that is where we are. So this raises a question for people like Girija and me, is UHC the real debate today for India? Is India ready for a UHC debate? Are we not got to go one step lower to look at the fundamentals that go to make for well-being? And I'll come to that again a little later. Amit gave a very provocative discussion on the entire concept of what does managed care mean, what are the pitfalls of contracting in private sector within an environment where the public sector itself, who's also supposed to be the regulator of standards, is itself very weak and doddering. I mean, international experience shows that a weak, underfunded, poorly managed public sector can never stand to the competition of private sector. But Thailand shows an example where a well-endowed public sector did drive the private sector out. So, you know, the point here is that private sector can be driven out provided the public sector is strong, well-endowed, well-funded, and well-managed. That's not the case in India. So to bring in private sector is to literally call for destroying and dismantling the little bit of the public sector that we have. Now, my last 2-3 points here I'd like to just reflect upon is the private provider payment incentives. Now, these are research questions because, you know, evidence to policy, this whole discussion today in 2 days is evidence to policy. My assessment of the kind of research work that has been done is a lot of cut and paste in India. We need to go beyond the NSSO. That itself is outdated. 60th round is 5 years old. And we're still hanging on, analyzing 2004 data to arrive at conclusions, when so much has happened since 2005. So there is a lot more analysis that we need to do. NSSO itself is inadequate. Far more questions need to be asked, keeping in mind the changing financing arrangements that are being called upon. For example, this whole essential drug policy, which let me tell you, I'm all for it. It's an excellent policy, but what is the evidence it is being based on? If you really look at it, 70-70 syndrome shows 2 lakh crores are being spent by the people of India on buying drugs. The whole drug market is supposed to be 50,000 crores, domestic market, of which the EML is supposed to be only 29,000 crores. So where is the remaining 1 crore 70,000 going? Now, if you look at NSSO, it is possibly not only drugs, but it's also diagnostics. Is that so? Are we then saying that 29,000 crores is the drugs, on essential drugs, and the remaining is going on diagnostics, and what is the policy for that? And just providing drugs in all the primary healthcare centers and public facilities, will it really drive down out-of-pocket expenditures as has been envisaged in the HLEG? Now, these are just numbers, but numbers must fit. And this is where I think much greater research needs to be done, because in this 29,000 crores also is a whole lot of drugs that are being provided free of cost by the government for TB care, HIV care, leprosy, malaria, fevers, and so on and so forth. So what is really happening in this whole paradigm is something that we need to really look at. In other words, go a little step further to say, yes, if people are spending so much money on drugs, where and who and on what and in what circumstances? Kerala, not Kerala, but Karnataka, Andhra, Bihar, everywhere you see quacks who are purchasing drugs and taking it to the homes and giving it to them on a credit basis, on purchase basis. Are these people now going to remove these quacks and go to the public health facilities just because drugs are being free? For a 3 rupee paracetamol coming free to them, are they going to be spending 50 rupees, losing their wages and traveling 5 miles to go to the PHC? Now, these are issues that need to be much more operational research needs to be done to say then how do we ensure that the people get access to drugs, expenditures are brought down, but in what manner does the design of the policy take place? Similarly, in the Arogyashi, RSBY, there is no evaluation, though we've done so much in terms of saying RSBY should be expanded. Arogyashi, every state is trying to imitate, but is there even one credible evaluation of these programs? No. And in Arogyashi, I've just read a paper, which is yet to be published, I think, shows that it has not reached, the benefits have not reached the poorest of the poor, that's the SCs and STs. The people who have accessed, and it's a universal health scheme in Arogyashi, because 85% of the population are covered and eligible, which is as universal as it can get, for a range of 900 surgeries. So it's pretty universal health coverage. But who has benefited? It is the richer classes and the middle classes. And if you see the track record of India's public policy, always we fight for a seemingly pro-poor policy which really affects and benefits the middle classes in the first round. So the point here is then what are the design features of RSBI they should have done to ensure that the poorest, in whose name this was done, at the cost of taking the budgets from the primary health care system to what impacts it is having. So the point really is that whether it's RSBY or whether it is, RSBY is full of the classical ills. I have enough evidence, and probably Malti is here, she can also speak about it later on, but the usual abuse, misuse, and so on that is going on. Now, these are things that we need to really study much, much more, because there are some good things that have been done, both in Arogyashi and RSBY, excellent documentation and very competent capacities have been developed, but also there are these abuses of the insurance system not reaching the poor. These are some things that we need to study. And finally, I would like to say, like, for example, in Arogyashi, Girija, what happened is that they started trying to incentivize the public providers to get what you have seen. Similarly, get the business to public providers. They started, since it was surgery-oriented, the surgeons were getting 30,000 rupees top-up for everything that they were doing, 30% of the full insurance package for them. So those who were doing medical treatment were getting their own salaries, but the surgeons were getting 3 to 4 times more in the same hospital. So you're using market principles into a public health system. Now, the money probably could have gone to the institute instead of the surgeon, so that the institute would have improved all the facilities and probably worked out a common bonus system to everybody. But since it is not done like that, there are a whole host of issues now coming up in the public hospital. So what I'm trying to say is there's a whole lot of work for all of you to do. Please do it. What India needs is evidence-based policy, not ideology, not impressions, not anecdotal data, not your view, my against my view. It has to be hard-nosed evidence, and this is where we need to take help from people like Professor Mills and others who really have got a solid research methodology grounding, and I congratulate Deva for bringing this to the fore, and I wish IHP all the very best in trying to promote evidence-based policies in India, which is a sore need if we really want an equitable and affordable, efficient health system in the country. Thank you very much. Please appreciate that I got it done in 2 hours and spoke as fast as possible, right?
2:15.
Yes, 2:15.
That was indeed a productive session that has unpacked the different perspectives around UHC. Now, I would like to thank Ms. Sujata Rao for chairing the session. I'd like to thank Professor Anne Mills for being with us and sharing her experiences from lessons from different countries. I would like to thank Professor.
May I just interrupt you all for a minute? Yes. Tomorrow you're going to get the Health Secretary, Government of India. I've been lobbying with him to say, keep at least a minimum of 100 crores in the 12th plan to promote research with institutions like IPH and so on. Please, all of you stand and make the demand tomorrow. I'm not here to remind you, but please do that and then do the research. They're getting 3 lakh crores for the next 5 years. So 100 crores is a peanut. You can ask more actually.
Thank you, ma'am. Now we would like to thank Professor Geeta Singh for being with us and sharing her experiences from HLEG. Would like to thank Girija Vaidyanathan for being with us and sharing her experiences from Tamil Nadu. Would also like to thank Amit Sen Gupta for being with us.
Much of this data is available.